Hello, everyone, and thanks for joining us. I'm Dave Iverson, contributing editor at the Michael J. Fox Foundation and the moderator for today's webinar on gait and balance, which is, of course, part of our continuing series of Third Thursday webinars. They take place every third Thursday at 9 Pacific, 10 Mountain, 11 Central, and 12 Eastern, where each time we'll take up a topic of importance to the Parkinson's community. And we hope you'll continue to join us for the remainder of this year and next year as well. Throughout today's webinar, you'll be able to submit questions, and we will take those up about halfway through today's webinar. There's a little Q&A box that you'll see on the screen, so just type your questions into that, and then we will do our best in the second half of today's webinar to answer as many of those as we can. We always don't, though, of course, get to everything, and so we have a kind of bonus opportunity which we offer each month as well, which is tomorrow on Twitter. That's at 12 noon Eastern. The hashtag is FoxPDChat, and we'll continue the conversation then and try to get to more of your questions that we don't get to today. So that's tomorrow at 12 noon Eastern. Two other quick notes before we get started. One is that the slides from today's webinar are available for webinar. So there's a box that says resource list, and then you can click on that, and then that will open up in a new browser window, and you can either save it or print it from there. And then finally, we also want to make sure we thank the sponsors for this Third Thursday webinar series. Those include Acadia Pharmaceuticals, Medtronic, and Teva. All right, let's get started with what we're going to be going over today. We're really going to focus today on this question of balance and posture and gait and how those changes are part of Parkinson's disease. We're going to talk some about why some of those symptoms seem to be less responsive to levodopa therapy than some of the other symptoms of Parkinson's, like tremor. We'll talk some, too, about the connection between cognitive abilities, particularly something called executive function, and some aspects of gait and balance. Then we're going to focus largely on ways in which people can really play an active role in confronting these problems through exercise and physical therapy, also some new developments in both medication and some surgical procedures, and we'll talk some about the research in all of those areas as well. Let's meet who's going to be joining us in our discussion today. Norma Semling joins us. Norma joins us from Eagle River, Wisconsin, beautiful place that I know well. She was diagnosed with Parkinson's in the year 2000 while raising two sons and also in the middle of starting a business. Since that time, she has started two local Parkinson's support groups to work with those who have Parkinson's as well as those who do not. Norma, thanks very much for being part of our conversation today.
Thank you for having me.
Joining us, too, is Dr. Chris Haas. Dr. Haas is an associate professor in the Department of Applied Physiology and Kinesiology at the University of Florida and is conducting some very interesting research that we'll hear about later in the program, as well as his comments on the role that patients can play in really getting active and dealing with some of these gait and balance problems. Chris Haas, thanks for being part of our discussion as well.
Thank you very much. Happy to be here.
And then we also have Dr. John Nutt. Jay Nutt. Dr. Nutt is the co-founder and director emeritus of the Oregon Health and Science University's Parkinson Center of Oregon and the Movement Disorders program there. Also active in a variety of research efforts that tie to these gait and balance problems. Dr. Nutt, thanks very much as well.
Well, Dave, thank you for including me. I'm very pleased to be here.
We're happy to have all of you here. And let's begin by a look at some of the issues that are prevalent in Parkinson's when it comes to gait and balance. And you see a kind of laundry list, everything that goes from reduced arm swing to small, quick steps, problem of balance and freezing. And Norma, I think it's probably most useful to get a first-person perspective on this as someone who is living with Parkinson's and is dealing with some of these symptoms. Tell us a little bit about your circumstance and what some of the gait and balance problems are that you're dealing with and how you deal with them.
Well, initially, when I first had my signs and symptoms of Parkinson's, I didn't realize it, but I was shuffling. I was favoring one side of my body more than the other. I was dragging one of my feet, and it was more noticeable by others. But that was something that didn't seem to affect me too much initially. But later on, I've developed a different gait where I'm having troubles. I definitely have a shuffle. I freeze up in doorways. I have difficulty when I'm walking by myself. I kind of feel like I need something to stabilize me. I use a cane where I didn't use one probably the first 10, 12 years of having Parkinson's. I've depended on other things and to help me move more so than I ever did.
And what has been effective for you in beginning to contend with some of those strategies? Have you been able to develop techniques for contending with some of those issues?
Well, somewhat. Initially I had to think of things that would help me. For example, when I look at a place I'm walking, if there's tiles on the floor, I can kind of walk from tile to tile. I can use my cane as a focal point, things like that. The medication helps somewhat, but I basically need to have some type of focal point.
And what about the role of exercise? I know that's something that you've said to me in the past has been important to you. Can you say something about how that's affected your being able to stay active and mobile?
Well, I've really learned sometimes the hard way that exercise is just something I need to do. It makes me feel better. It's a mind and body thing. It helps you to relax. It helps you to keep your muscles strong. Without exercise, I wouldn't be where I am. I used to be an avid exerciser. I went to aerobics classes and different things, and that's changed somewhat because when I go to classes now, it's a little more difficult to keep up with the average exerciser. But I've learned to do what I can. You don't have to follow along exactly in a group, but you need to do something that you can do just to keep yourself active.
Well, that's a really useful perspective, I think, and being able to do what you can and stay engaged with this. And thanks for starting us out with your experience, Norma, and we'll be hearing more from Norma throughout our hour today to get that important first-person perspective. Let's involve Dr. Jay Nutt and Dr. Chris Haas in our conversation as well. Dr. Nutt, first, we heard Norma describe some of the issues that she is contending with, and she talked about a couple of strategies that she uses. Can you say something about, for example, with that problem of going through a doorway? That's something we've heard a lot about. Do we understand what's happening in that case where someone starts to freeze or has to create a focal point where they take a step to get through a particular obstacle like that?
The basic answer is no. We don't understand why doorways are such a problem. I mean, it has something to do with how wide the door is and thinking about passing through it, but we don't really understand. But I think what Norma did is really describe tricks, and I think what those tricks do is take you from thinking about walking. And when you think about walking, you have no idea how you actually walk. But if you reduce it to taking one step, we have a much clearer idea of how you do that, and you can think that through. And so I think targets, and we often have patients use masking tape that they will put down in areas that are constantly a problem. And you can have the masking tape down as a strip, and the person can think, well, I have to step over that strip and then the next strip, and having to target, and that often really helps people move through those difficult areas. Doorways, it's often a problem in small areas where you have to turn as well. So kitchens and bathrooms are a major problem.
And can you also say something more, Jay Nutt, about the problem of freezing in particular? Already a couple of people who are participating in our webinar today are asking, what does that actually mean? Norm writes in, what does freeze mean? We see that in the fourth bullet point, and Norma describes some of that experience. But what exactly is going on when someone freezes?
Well, freezing refers to the inability to either continue walking, but more commonly to start walking. And the patients that experience that almost always describe a feeling like their feet are stuck to the floor. And I had one patient who was convinced that the VA hospital where I saw him had magnets between the floors that they would turn on at times and make his feet stick. And turning is perhaps the thing that will bring out freezing the most. People just get stuck and they can't get their feet to move.
And Chris Haas, we're going to talk more a little bit later in the program about additional techniques, but since we're already into these things, and I think people are most concerned about how they can contend with some of these issues, I know one of the points that you think is important is that people have to get on this, as Norma did, early on. You can't wait to have problems before you start dealing with it in terms of whether that's exercise or a physical therapy regimen.
Yes, exactly, Dave. We feel that it's incredibly important for people living with Parkinson's disease to play an active role in the treatment and the fight against the disease. And we know with gait deficits and balance deficits, we think obviously there's a certain component of it that's related to the lack of dopamine, but then there's also other systems that are perhaps involved, and then we rely on compensatory mechanisms to kind of override those, kind of like we talked about with the tricks. And we can do these things effectively maybe early on in the disease, but as the disease progresses, that becomes harder and harder. So that's why it's really important for us to try to intervene early when we have the greatest amount of resources available, and whether it be physical therapy. And our real key theme for us is that we want to see people living with Parkinson's disease prior to the time that they fall, or prior to the time where their gait and balance deficits are really impacting their lives. And when we can do that, we can increase their quality of life. We can target specific aspects of their symptoms that can have a big influence on what they're trying to do.
So as you look at this list
Dave, could I?
Go ahead, Dr.
Dave, could I add? Could I add to that for just a second? So I would like to just really emphasize what Chris has said. And when I see a newly diagnosed person, I always tell them that if you look down the road, the thing that is going to affect the quality of life the most is probably a loss of mobility. And the time to start preventing or delaying that is now. And so we emphasized from the first time we see the patients about how exercise with balance is really important. So I think that's really critical.
And we'll talk more as our webinar progresses about some specific techniques and the kinds of things that people can do. But before we get to those techniques and the research that's going on, let's try to learn a little bit more about what's going on inside someone with Parkinson's and why it is that perhaps the standard therapy that so many of us take, combinations of dopamine replacement, whether that's carbidopa, levodopa, or a dopamine agonist or some form, are somewhat less effective with these symptoms. So that's the subject of this next slide. And while it says here that levodopa can help with some of these symptoms, like how well your arm swings, it seems to be less effective with others. And is that, Chris Haas, in part because there's more going on in Parkinson's than just dopamine loss, that as we're learning about the disease, this is a multifaceted condition, and dopamine isn't the only thing that goes amiss. Is that at the heart of why these problems are difficult to solve?
Yes, absolutely. I think that, we really latched on early on in the study of Parkinson's disease is that it's a single problem, and that's the lack of dopamine. But as we've gotten much better in our techniques and we've been able to quantify what's going on in different regions of the brain, as well as measuring different brain chemicals, we understand that it's probably much more complex than just a simple loss of dopamine. And as you can see in the slide, another compound that's listed is acetylcholine. And we know that the cholinergic system has widespread influence on a number of functions in the human, including cognition, how well we think, how well we can attend to things, as well as gait and balance. And now we're starting to see in research studies and in patient populations that we're starting to see cholinergic dysfunction is becoming more prominently observed in our patients. And so they're certainly, as we have the issue with dopamine, as we have other neurotransmitters that are declining in other areas of the brain that might be undergoing atrophy or plaque buildups, et cetera, these areas unfortunately also influence the way we walk and the way we move.
And we'll learn more about some new research approaches that Dr. Nutt, you're involved in terms of whether or not boosting acetylcholine may play a role in improving some of these functions. But before we get to that, I don't want to skip over one point here, which I think is important. And actually, there was some news in the research community about today about dyskinesia, which are those excessive movements that can sometimes happen over long-term use of levodopa. And there was some news out of Northwestern University today about perhaps some new hope for a drug that might eventually help contend with dyskinesia. But Norma Semmeling, let's bring you back into our conversation, because you said that dyskinesia, those extra movements, also can increase the problems you have with gait and walking. Can you describe that a little bit, Norma? And then I'll ask you, Dr. Nutt, to comment on that as well. But Norma, what's been your experience with that?
Well, first of all, when I'm not moving a lot with the dyskinesias, I have a smoother stride. I'm able to have more controlled movements. When I have the dyskinesia, I'm all over the place. And depending on the level of it, I can have my cane in my hand. In fact, my husband always says, "You're going to knock somebody out with that thing because I don't realize I'm moving it and swinging it." And I tend to just not have, like I say, the control that I'd like to have. Even sitting here this morning, I've got some dyskinesia, and the phone's probably moving all over more than I'd like it to be, and different things. It makes me speed up the things I'm doing, and that's not good. I need to learn to slow down. And exercise and stretching does help that tremendously.
Mm-hmm. And Dr. Nutt, describe something about how you deal with that, because it seems to me a kind of classic example of how tricky it is with Parkinson's. You have a drug that's helpful in so many ways, but in time can actually cause problems of its own by these prompting these uncontrollable movements, which in turn then can compound the gait issues of Parkinson's. So how do you balance that, so to speak, in how you work with patients with the kind of issues that Norma is describing?
So Dave, it's an incredible problem, because a lot of times if you can always lower the levodopa, and that will reduce dyskinesia. Sometimes what you can do is you can keep the levodopa the same and lower dopamine agonist, or maybe if somebody is on rasagiline or Hazelect, you can get rid of that. But still, it turns out if you get rid of dyskinesia, you almost always are going to make the Parkinsonism worse. You're going to have less control. The other thing that can be done, and this may be the news, I'm not familiar with exactly what news came out of Northwestern, but there's a lot of attempt to find drugs that will suppress dyskinesia without affecting the response of the Parkinsonism to the levodopa. And the one drug that we have that will do that to some extent is amantadine. So we will often add amantadine and try to suppress dyskinesia to some extent with that.
Great. Let's move into our next area, and then we'll soon start taking all of your questions. I know there are lots of people already asking what kind of exercise is best, and we'll get our best responses to that in a moment. But I want to take up one other aspect of this before we start talking further about how we deal with these gait and balance issues. And that's actually tied to what Chris Haas was just saying about the role of acetylcholine as one other neurotransmitter that's involved in Parkinson's. and its connection, as Chris was saying, not only to balance issues, but also to the problem of cognition. So let's dig into that a little bit, because as you were saying, Chris Haas, this is tied to both how well we think and perhaps how well we walk. And this is a fascinating area of Parkinson's because, as you've both you and Dr. Nutt have alluded to, walking isn't something we normally think about a lot. It's something that happens in an automatic kind of way. But in Parkinson's, sometimes those movements become less automatic, and we have to think about them. But if we're having problems with some of our thinking processes, then that in turn makes walking more challenging. Give us kind of a sense of the way in which that interplay takes place.
Sure, and as you mentioned, Dave, we think that traditionally that gait is controlled, maybe perhaps or walking is controlled by kind of a direct pathway that is very kind of motor-based. But we also know that there's an indirect pathway, let's call it, that regulates our movements, that takes into account things like attention and executive function, and these processes are going to allow us to do things like adapt our gait. And when we're walking in a complex environment, maybe the mall, or if we have a impaired gait, such as our people living with Parkinson's disease, then the executive aspects weigh more heavily, and we have to use those aspects to help make our traditional normal walking, which is automatic, become less automatic. And as you said, there appears to be an association between several aspects of cognition and walking function. The association seems higher, so there's a greater relationship between cognitive abilities and walking function in patients that may have the PIGD subtype, maybe perhaps more so than individuals that have the tremor dominant subtype. But certainly
PIGD refers to, sorry to interrupt, Chris, but just to clarify that.
Postural instability.
Right.
So those patients with postural instability and gait dysfunction as their primary symptom have a greater association between their cognitive faculties and their walking abilities than do individuals who have a predominant symptom of tremor.
It sounds unfair, the very thing, if you're troubled by gait issues, the function you need most sometimes is to perhaps bring more focus to that, and what you're saying is that also is challenged in that same situation. Has that been your experience, Norma Semling? Do you feel like your own that so-called executive function, the ability to multitask, is part of what also sometimes makes it challenging when you want to, as far as how that affects your ability to walk and move?
Oh, definitely. I try to do so much. I try to keep really busy. I paint, I write, I do different things, but it's very difficult when I'm moving a lot and I try to sit and write a poem or try to paint a vase or something. Sometimes I just can't do it. I have to slow down, and it really has a big effect on me.
And what can be done about that, Jay Nutt? Are there strategies to contend with if your ability to multitask is somewhat challenged? What do you have to then try to do if you're walking in that complex environment that Chris Haas was describing? Let's say you're in the grocery store and you have your grocery list in front of you. What do you suggest that people do so that if they're focused on their grocery list, they don't forget to take the next step, or vice versa?
Well, actually, the grocery store is one of the easier places to cope with because you have shopping carts.
Yeah, right.
And so having a shopping cart that you're holding on to with one hand will often really help with that. But it's places where you don't have a shopping cart that it can become more of a problem. And just one thing we haven't really touched on freezing is generally a person may have freezing when they're turning, when they're in tight quarters, but if they're walking in a straight line someplace, they actually can do quite well. And many people find that if they get outside and start walking down the block, they're fine. It's actually getting out of the bathroom, getting through the house, getting down the steps. But once they get outside and there are less distractions and they're just walking in a straight line, they do much better. I mean, the other thing is we generally tell patients that you shouldn't try to carry things, because trying to carry something, balance something, and walking can be a problem. And I think that it's hard to not be dual tasking all the time, because there are people are talking to you, you're interacting with things, you're carrying things around. But one thing is to try to, when you walk, is to just focus on walking and not trying to do other activities simultaneously.
Yeah. Chris Haas, anything you want to add on that point of how to contend with those dueling problems?
Yes, thanks for asking. I think that, as Dr. Nutt suggested, those are some great ideas. I also just want to point out that in a safe environment, working with a therapist or a personal trainer, practicing dual tasking might be an effective strategy to actually get better at dual tasking, or practicing cognitive skills might also be a way to improve walking abilities. But the important thing is it needs to be in a safe environment where you can, if you do become disabled or lose your balance during the said practice, that the likelihood of falling is very small.
And by practicing, when I was at the gym the other day, it's also a place that has physical therapists, and next to me I heard a physical therapist working with someone on their walking, and she was saying, okay, now this time as you walk, I want you to count backwards from 100. Is that an example of sort of practicing, thinking about something that's challenging while you're walking, but doing it in a safe environment because your physical therapist is right there beside you?
Exactly. We've seen things just like that with counting backwards, naming things, etc.
All right, let's dig into what we can all what we're able to do in terms of the kinds of exercise we can do, the kinds of strategies and techniques we can apply, and start taking all of your questions as well. Chris Haas, let me just stay with you for a moment. We see a lot of different things there under physical therapy as far as the importance of doing it early on, what you refer to as prehabbing rather than rehabbing, and various training options to improve strength and balance. But a lot of people are just saying, well, what's the best thing to do? So do you have an answer to that question? Always comes up. What's the best thing that I can do?
The best thing is doing something. We don't know, frankly, we don't know if, let's say, walking on a treadmill is better than lifting weights, which is better than doing Tai Chi. With that said, certainly there are certain features of the disease or the symptoms that may be better targeted by some interventions. So, for example, if a person has problems getting out of a chair, we know that increasing leg strength, so by exercising the fronts and the backs of your legs and both the upper and the lower legs, has been shown to increase the ability to get out of a chair. So, what I said, there's no perfect exercise. All of them have strengths, and truthfully, finding one that you like to do is probably more important than if it's the optimal one. And I'd also like to make a comment. Good.
Go ahead.
One other comment would just be is that I think we hear this word exercise and it becomes intimidating. And we've been told really all of our lives that we should exercise. And then now we have a neurodegenerative disease, and now it's like, oh gosh, exercise more. And that can be very daunting. But truthfully, just doing something more can have its benefits. Standing more at the house instead of sitting. So standing when you're working on the computer rather than sitting when you're working on the computer. There's lots of evidence that's coming out in the older adult literature and now some in the Parkinson literature that suggests that just increasing your daily activity, even if it doesn't reach the level of defined exercise, can have its benefits.
And Dr. Nutt, do we know definitively now that exercise and physical therapy do indeed make a difference? Not necessarily perhaps in whether or not they slow down what's going on in terms of the biological pathway of the disease, but do we know that they absolutely improve people's symptoms of Parkinson's, whether that's gait speed or any number of other things? Is that a known?
Dave, I think we can say yes, that is known. It is known. I mean, there have been a number of studies that have suggested that exercise helps, and not just gait and balance, but in general. Exercise also helps people's mood, which can be a problem as well with Parkinson's disease. So exercise definitely helps. But what we don't really know is what Chris was just saying. We don't know what is actually the best exercise, and there are a variety of things that you can work on. Here, our group really focuses on what we call agility, which is not just balance, but the ability to move if you start to fall, to be able to take a step to correct. So we tend to really emphasize that, but that it's not certain that that's actually better. And we should really mention one of the new fads, which I think is really interesting, and that is non-contact boxing. Mm-hmm. And the reason that tends to be really good is you're shuffling your feet as you're moving around, and you're also working the spine as you're trying to hit the bag or hit the hands of the trainer that's working with you. So that is a new thing that the people that participate, and there haven't been that many yet, but many of them really think that that's been the best thing that they've had.
There are a couple of questions coming in about a few other things that we'll touch on, and then I want to bring Norma back to talk about a couple of her own tools and tricks. But Chris Haas, a few people are writing in and asking about dance as another sort of new interest that people have developed that perhaps has some additional aspects to it because it involves sort of both mind and body. You're learning things as well as moving.
Absolutely. I think dance is wonderful for patients with Parkinson's disease. It has lots of features that are very beneficial. One, there's a large social aspect, which, as Jay mentioned, there's a very positive emotional response for group exercise in these individuals. Two is that we know that auditory cueing is also beneficial for patients and their walking abilities. So there's the moving to the beat aspect of dance that's very nice. Then there's the learning of step patterns, right? So there's a motor learning component to it as well. The other thing that's nice about dance is that you can make it kind of as hard as you want to by increasing the speed of the music or the beat of the music, or by flexing your legs more during certain movements. So yes, dance is one of the things that as a global exercise, I think it has quite a large number of benefits.
Let me ask one point about the very last bullet point on this slide before we go on to research and open up to the rest of our questions that are coming in, and that's on social interaction that both Chris Haas and Jay Nutt have mentioned, Norma. And I wanted to ask you, Norma, for your point of view about that aspect of participating in exercise, but also participating in life in general, because I know you've been engaged in starting various support groups. Can you say something about how those kind of work hand in hand, social interaction as well as activity and active engagement?
Oh, definitely. We all need to discuss our situations with our physicians and, our caregivers and such, but just being active in a support group where I found a lot of my meetings where we all talk amongst each other and stress our issues and our problems, and we find out what the other guy is doing that helps him, that may help us. And we really learn so much about not only the people that have Parkinson's, but ourselves. Just getting together in a group can make a tremendous difference. Just getting out into public, making people aware that of what you have. I bring up the grocery store end of it, and so many times I'm in a grocery store and people see me walking, and I'm having difficulty, and they say, "What did you do to your leg?" or or "Do you have MS or something?" They don't understand until I tell them that I have Parkinson's. So it's an awareness thing. The more you're aware and the more you deal with other people, the better off you are.
And I know I've been in group situations sometimes where people also then pick up techniques from each other. Someone will say, well, this is how I manage, a particular obstacle. This is how I get up out of a chair. And sometimes it's a helpful way of picking up kind of tricks of the trade, so to speak, from people who are contending with some of these same issues. Let's move on and bring in sort of what the potential is, and I'm now going to start folding in more of your questions as well, particularly on this very first area of deep brain stimulation. This is an area that you're working on, Chris Haas, and a lot of people are wondering about DBS. There's the traditional form of DBS, which is quite helpful for tremor in particular. But some people are wondering about whether or not DBS, the traditional form of DBS, can that make gait worse? Can that make cognition worse? Since we've talked about both of those two things, because there has been concern about that. So if you would, Chris, respond to that worry about traditional DBS, and then I'll ask you something about sort of the new research that you're working on for a new form of DBS.
Sure. I think that it's important to realize that DBS is very effective for many symptoms in well-selected and well-screened patients, and from a very experienced team of neurosurgeons and movement disorders neurologists. And we know that it does a very good job whether the target is STN or GPI, so two areas within the brain. We can see large improvements in tremor and rigidity, maybe bradykinesia. And we also do see improvements in some aspects of gait, including gait speed, stride length, some arm swing benefits as well. But as you mentioned, there are some potential side effects that we do see. And in some patients, we see a reduction in cognitive faculties after DBS. And certainly that's a concern that patients should be aware of when they're making the decision with their doctors if DBS is right for them. We also know that in a subset of patients, perhaps, and it's not clear who or why, but STN stimulation may aggravate dysfunction within a brainstem area that's very important for gait function and balance function. So the stimulation might be causing more issues with this area, which we refer to as the pedunculopontine nucleus, or PPN, as our patients might now be hearing about.
So traditionally, DBS has been targeted to those two areas you mentioned, GPI and STN. And this gets kind of complicated, so we'll just stay with the initials for now and say that those are two areas of the brain where DBS has traditionally been applied, the electric stimulus. You're researching applying that same stimulation to a different area of the brain, the pedunculopontine, or PPN, and with the hope that that can improve gait and perhaps prevent freezing episodes. Real briefly, if you would, Chris, because I want to make sure we get to all of our participant questions, but can you describe what your hopes are for that form of that new form of DBS that you're engaged in researching?
Certainly. We know that the PPN target plays a large role in gait function, and we also know it's a prime releaser of acetylcholine into the cholinergic system. And so we feel it's an important target, or a potentially important target, for stimulation to improve gait dysfunction. But with that said, we're also taking maybe a little bit different approach, and the idea is that we know that patients aren't continuously walking. We do things in daily life. We sit, we sleep, et cetera. And so the idea that we're approaching is perhaps we can use a targeted DBS that only activates the PPN at times when patients are walking or at times when freezing episodes are occurring. And so ultimately we'd like to be able to sense when the brain is about to cause a freezing episode, and then we'd be able to then stimulate the PPN to help squash that to get the patient out of the freezing episode.
Fascinating stuff. It's sort of smart DBS, kind of DBS on demand. And I know it's being researched not only at the University of Florida, but at other universities around the country. And it's a fascinating development that I think we'll all watch with great interest. Let me ask you, Dr. Nutt, if you would, to comment on the other area of which I know you're engaged in researching, because a number of people are also writing in and asking about this, which is, well, you've mentioned acetylcholine as being a problem in Parkinson's. How about boosting acetylcholine, which I know is the very research that you're engaged in. Tell us something about that, please.
Well, Dave, what we know about acetylcholine, some of the more compelling evidence comes from some very sophisticated imaging where they're actually looking at acetylcholine in the brain. And researchers at the University of Michigan have shown that if you have decreased levels of acetylcholine in the cortex, that relates to poor thinking, and it also relates to gait speed, that you have a slower walking. And there's another set of acetylcholine that comes from the PPN, as Chris just mentioned, and that goes to the thalamus. And if acetylcholine is decreased there, that actually is correlated with falls in Parkinson's disease, not with gait speed and not with cognition. So there's that type of evidence that acetylcholine is important. We are funded by Michael J. Fox Foundation for a clinical trial that we're doing in which we're looking at the effect of a drug called donepezil. It was marketed initially as Aricept, and that drug will block the degradation of acetylcholine, so it augments the effects of acetylcholine in the brain. And so we were looking at that and looking at the effects on both walking speed and on falls and balance. So we are looking into this.
And that's a drug initially used in the treatment of Alzheimer's. Is that right?
That's correct.
And
it's interesting that you bring that up. So in Alzheimer's disease, there's low acetylcholine in the cortex, and but it's all this acetylcholine is coming from either the pedunculopontine nucleus or from some other nuclei right at the base of the brain, and those nuclei also degenerate in Parkinson's disease, and perhaps to a greater extent than in Alzheimer's disease. So there's lots of reasons to think acetylcholine might be good, and be good for both thinking and for gait and balance in Parkinson's disease.
Well, as with the research that Dr. Haas is working on with DBS, I think these are both, and I'm sure all our participants would agree, fascinating areas to pursue, and we'll be eager to learn more as your trial process continues. Let's go ahead and start taking more of your questions. There's so many that are coming in, and I want to get to as many of them as we can. Here's one, Chris Haas, that perhaps you can take. Well, actually, Norma, why don't you respond to this first? A number of people are asking about driving and the impact on, and whether freezing concerns impact whether or not someone is driving. How have you dealt with that, Norma? Have you made a decision? Are you still driving? What have you thought through on that regard?
I am still driving. It has become something that I've thought more about lately, especially now living in northern Wisconsin and knowing that the roads are going to start getting icy, and with my anxiety, that doesn't help. And if I'm moving a lot, I'm not safe. So I'm to a point where if I don't feel safe, I don't drive, but I'm sure it's going to come to a point where I probably shouldn't drive, and I really have to respect that. So, but right now it's keeping me independent, but I don't want that to be something that holds me or that keeps me driving. I need to be safe for me and other people.
Sounds like you're approaching that with a lot of thoughtfulness and wisdom. And this is a tough one, Jaynut. I'm sure you've dealt with it with your patients and patient spouses before. How do you suggest that people come to terms with answering that question?
Well, I would just like to add one thing. We've talked a lot about problems with doing two things at once, multitasking. And I think you have to realize that driving is an incredible part of multitasking. I mean, you're looking for the turn up ahead. You're looking at the person who's posed on the edge of the curb, getting ready to walk in front of you. You're trying to keep track of the car that's behind you on your left. And so oftentimes it's the multitasking that can make driving really difficult. But I think there are the motor aspects of this as well. And I think there are a variety of things to do. I mean, one is to have the family report on what they feel when they ride in the car with the person. Another is physical therapists can do a variety of testing, some of which includes multitasking, to see whether they think somebody is likely to be safe. And the final thing is we send some patients back to the licensing bureau and say you need to have a road test with a professional to evaluate your driving.
And perhaps the most important thing of all is I think perhaps to emulate Norma's thoughtfulness and wisdom in the way in which she's approaching that, trying to balance both one's own need for independence, but as important, perhaps sometimes more important, making sure that everyone is safe. And I commend you, Norma. I know it's a tough one, having dealt with that in my family too, to come to terms with. A lot of questions, Chris Haas, about boxing. Jaynut brought that up. I'm curious about your perspective on boxing and what it offers. It's something that's gotten lots of attention and lots of interesting stories. Fascinating story on CBS Sunday Morning a couple of weeks ago about boxing and Parkinson's.
Sure, I think there's a lot of important features of boxing that can impact quality of life and movement abilities of our patients. As Jay mentioned, it's an upper extremity and lower extremity movement, roughly at the same time. So you have to work on coordinating your legs position at the same time that you're beginning to swing the arm. And it's also interesting that, when you swing your arm forward to deliver the punch, that destabilizes your balance. And your body has to respond prior to that swing, or you will swing forward and fall forward. And so it's really a way for our patients to practice purposely destabilizing themselves. Well, when do we do that? We do that when we take a step. We have to purposely destabilize ourselves. When we get out of a chair, we have to purposely destabilize ourselves. And so boxing is a nice way to help train those areas where we have to purposely destabilize ourselves in a safe environment. Two, I think it's, we don't talk about this much, but boxing is a nice way to get rid of anger. And to get rid of, and a lot of times our patients are angry. They're angry, and it's a great way for them to relieve some of the stress of having to deal with some of the symptoms that are very disabling. And so that can be very uplifting and rewarding when you're delivering that nice blow, when you hear that pop of the glove against the bag.
We should probably clarify that that's what's going on. You're hitting a bag, not another person. So
right, exactly.
That aspect of it is at least you're not creating problems for someone else. A question, Norma, that maybe you can respond to first, and then either Jay or Chris can add on to. But Norma, this person asks, how can a partner or caregiver be most helpful when walking with a loved one with Parkinson's? Have you and your husband, Norma, kind of worked out a technique for that you find useful?
Yes, we have. In fact, we try to walk quite often. We usually go in the morning, and we've got 2 dogs, so he'll actually motivate me by asking me if I'm ready to go for a walk, and sometimes I'll say, I don't know, I'm just not sure, and then he'll give me this wah wah wah, just kiddingly, but we walk together for like 1.5 miles, and it's time for us to talk. It's time for us to enjoy the outdoors. And it really works, and I feel so good when we're done. He's really great about that.
That is actually always one of the best parts of exercise, is how you feel when you're done. Chris Haas, anything else from a technique standpoint if someone wants to be helpful when walking with one's partner?
Sure. I think the key is to provide light touch, either allow the person living with Parkinson's disease to touch you lightly. We know that haptic feedback is very important for maintaining balance, or deliver a light touch to the person walking, because too heavy of a touch, you can destabilize them, and then you're pulling them off balance every time that you're walking. So we try to focus on a light touch.
Question about posture. Chris, I'll just stay with you for this one. We haven't really talked about that. What about posture? Are there things that can be done? And first, what's the problem in posture with Parkinson's, and then what can be done?
Sure. So we see the typical forward inclination or forward trunk lean. And what that does is it moves, from a mechanical perspective, it moves your body's mass closer to the front edge of your feet. It makes it harder to control your balance. So the further your body gets out in front of your feet, the harder it is to maintain balance and stability. Certainly our persons living with Parkinson's disease that are listening know that they can stand fairly well upright if their spouse yells at them and reminds them to maintain upright. And so we know that there are triggers that we can use, these reminders, et cetera, but also activities that can strengthen the muscles on the back side of the body to try to pull the chest back. We do a lot of computer work now, and so we have forward rounded shoulders, which further makes the forward posture associated with the disease more troubling. So trying to open up the chest, to expand the chest, which will help with breathing, and then to pull the muscles in the back backwards.
Dr. Nutt, a couple of questions about pain and cramps, which we haven't really talked about. Dystonia is something that can happen in Parkinson's, those painful cramps that can happen in the lower extremities. John asks, is that pain that I have in my lower extremities associated with Parkinson's? Ken asks, if I have cramps, what can I do about them? Thoughts about pain and those dystonic or dystonic cramps that happen in PD?
Okay, Dave. So there are lots of aspects to this question. So first off, just about pain. And there's definitely pain in Parkinson's disease. Some of this is just arthritis and other things that we accumulate as we get older. But some of it is clearly related to the Parkinson's disease. And the clue that is what is happening is if the pain gets much better when the levodopa is working. So if the pain is primarily when you're off, then it may well be related to the Parkinson's disease and just levels of dopamine. The cramps, I really think the best thing can be done with cramps is really stretching, and stretching particularly the calves, and doing that for a couple minutes several times a day. Now the dystonia can affect any part of the body, but very commonly it's in the toes or in the ankle. So the toes may curl down, the toes may curl, especially the big toe may extend up, or the ankle may turn in, and so people end up walking differently, and especially if they're walking on the side of the foot. And sometimes what we can do for that is use Botox injections to weaken those muscles that are pulling the toes and the ankle into an abnormal posture. Occasionally we try to brace for that. Chris must see a lot of this. Chris, do you have any other comments?
No, I agree, and I think that one important aspect to determine too is if the pain is related to cardiovascular issues or claudication in the legs. So we need to make sure that it's as we said, PD related pain, or if it might be something else that's going on. And then certainly you can adjust the exercise program that you may be interested in, such as doing things in the pool, for example, where your body weight will be reduced and you can still get the resistant movement from the water, which shouldn't aggravate the abnormal positioning of the foot.
Chris, could you add something about the importance of gait speed? This is, to me, one of the more fascinating things I've learned in recent months, that how fast you're able to walk, which doesn't mean speed walking, but being able to walk at a good pace is very much tied to how independent someone is and how long they're able to maintain their independent quality of life. Seems obvious in a certain sense, but it's not something I'd necessarily thought of. And can you describe why being able to not just walk, but be able to walk at an okay clip is such a crucial ability to maintain?
Sure. It's becoming more and more reported in the gerontology literature that gait speed is kind of the next important cardinal sign of health. And the idea there is that when individuals lose the ability to walk at a fast enough pace, it really kind of gives a sense of that there's multiple systems that are declining. And then functionally, what does that mean? It means that if you're not able to cross the crosswalk before the clock times down, then you're not going to be able to explore your neighborhood. You're not going to be able to explore your environment, which then can lead to more sedentarism and then more cardiovascular issues. And we know that from this literature that gait speed is predictive of future mortality and morbidity.
And can you improve it? Is that something that you can see people improve through the course of whatever they do with a therapist or with exercise?
Sure, absolutely. And we do see improvements in gait speed and walking speed with levodopa therapy, and we do see improvements with DBS, and we do see improvements through physical therapy and exercise.
A couple of more quick questions, and we'll get some last closing thoughts. Dr. Nutt, Wasim writes in, is there a pattern, and a couple of people have actually raised this, do gait problems tend to be worse in the morning or at night? And if so, is there something I can do preventatively to assist?
Well, that's an interesting one, and I would think that this really depends a lot on the individual. So certainly some people, when they get up in the morning, they haven't had drug overnight, they may have these painful cramps and dystonia, and those people are going to have a lot of trouble walking in the morning. The trick there is to have the medicine at your bedside, to take your pill and stay in bed for another 15 or 20 minutes, daydream, plan your day out or whatever, and then when you get up, you're going to be able to walk better. Then I think another pattern, of course, are people that kind of wear down during the day. And I've become an advocate for people that wear down to sometimes suggest that they take a brief nap, 15 or 20 minutes. And they should experiment with this and see if that, when they get up with that, they're refreshed and their walking and balance and such is better. It may also have to do with exactly how their medications have been arranged during the day, and you might find that there is one particular time that the medicine just doesn't seem to work, and you can work around and see whether this is absorption or maybe you need a slightly smaller dose or something like that to promote their function. So there
just have a moment.
Lots of reasons.
Yeah. Just have a moment left, so let me ask you each just for a kind of last takeaway thought. And Jay, let me stay with you for that first. What would you like people most to take away from this discussion?
Well, I think the big thing that that I'm pushing and our group is actually pushing is exercise and exercise starting early. And we don't, I think telling somebody to exercise isn't very helpful. And so I think you need to give them ideas of what the programs would be. We're fortunate in Portland in having a number of exercise groups that are directed at Parkinson's disease. I mean, there's Pilates and there's Tai Chi, and I think getting in a group for exercise is helpful. We often use the physical therapist to first evaluate the patient, suggest what might be good for them, but we try to be really more directive and really help them find an exercise program. And then I think there are other tricks that can help people stay active with exercise. Sometimes the groups themselves are really motivating. I think getting the spouse involved. I mean, exercise is good for everybody. It's not just for Parkinson's disease. So getting the spouse involved so that they are also going to exercise classes with the person who has Parkinson's disease. I think those are other tricks. So I would say emphasizing exercise and doing it well before there's even any hint of gait or balance problems.
And Chris Haas.
Yes, for me the most important take-home message is to participate in your treatment. And the few ways that our patients can participate in their treatment is by being more active, going to exercise classes, going to dance classes, going to physical therapy appointments. And so we really stress, participating in the fight against PD.
And Norma Semling, last word from Eagle River.
Well, I just think it's important to take time for yourself, learn what you need to do to help yourself, and you can help others more that way, and you'll just have a better life.
Thank you, and thanks so much, Norma, for your participation today, and for all that you are doing to help people stay engaged in your community and elsewhere. Also, really want to thank Dr. Jay Nutt from Portland, Oregon, and Chris Haas from the University of Florida. Thanks so much for your participation. Just a reminder that we can always value people participating in research. What's on our screen now is a way that you can be involved in research. It helps further not only dealing with problems like gait and balance, but Parkinson's research in general. And you can always watch our previous webinars by going to the address that's on your screen. We'd like to also ask you to mark your calendar for our next Third Thursday webinar, which is on December the 17th at 12 Eastern Time, where we'll go through some of the research highlights from 2015. It's been a really active year in the research community, and it's a good way of getting a sense of the progress that is being made. And again, if we haven't gotten to your question today, we'll have a follow-up conversation on Twitter. The hashtag is FoxPDChat to continue our conversation on gait and balance. Thanks all very much for your participation. We'll look forward to our next Third Thursday webinar on December the 17th. I'm Dave Iverson.